Hi guys, so welcome to today's session on GI. So we're doing liver disease today. My name's Catherine and I'll be presenting alongside Alex, and we'll be discussing some key aspects of liver disease, so including things like cirrhosis, liver disease, jaundice, liver transplant and HCC. So let's get started. All right. So, in terms of learning outcomes, like I said, we're going to cover key areas like cirrhosis, liver disease differentials, jaundice, liver transplant indications, and hepatocellular carcinoma. So, like usual, we're going to go through 10 kind of SBA style questions. We'll let you kind of answer the question as we go along, and then we'll go through an explanation afterwards. All right. So, our first question, a 65-year-old man with a history of chronic alcohol use presents with increasing abdominal distension. He has a history of cirrhosis and his recent ultrasound shows ascites. His liver function tests show a drop in albumin levels and elevated bilirubin. Which of the following is the most appropriate first-line treatment for his ascites? So I'll just give you a few seconds to come up with an answer. So the right answer was B, so diuretics like spironolactone and furosemide. So ascites is a really common complication of liver cirrhosis, and diuretics are the first-line treatment to manage fluid retention in ascites. Things like paracentesis, which was also an option, can also be used to help with the symptoms, but we usually try and use diuretics first. An albumin infusion can be required in some cases as well, where people are kind of nutritionally not so great and things like that. But the first line thing is a diuretic. So there's lots of different causes of ascites. So today we're going to focus on liver-related ones like cirrhosis, alcoholic liver disease, hepatitis or Budd-Chiari syndrome, but things like cancer, heart problems, kidney problems, infections, and other things can also cause ascites. And these slides will go out kind of anyway, so you can have a read through those in your own time as well. So in terms of treatment, like we said, the first line is diuretics in terms of our treatment, but also along with that, we'd encourage sodium restriction, so less than 2 grams a day, along with fluid restriction, especially in severe hyponatremia. If there's an infection or they're symptomatic of any infection, then we give them antibiotics for any bacterial peritonitis. Like we said, things like paracentesis can be done. And most importantly, we try and work out what the underlying cause is. Like we discussed before, there's lots of different causes of ascites, but also try and treat that underlying cause to make sure that the ascites doesn't come back. Fine. So moving on to question 2. A 48-year-old man with a history of heavy alcohol use presents to the emergency department with jaundice, nausea and vomiting. He reports recent heavy drinking. His liver function tests show an AST to ALT ratio of 2:1 with an elevated bilirubin and GGT. What's the most likely diagnosis? Again, I'll just give you a few seconds to work that one out. Fine, so the correct answer in this case was A, so alcoholic hepatitis. So an AST to ALT ratio of 2:1 is characteristic for alcoholic hepatitis. Management options kind of include things like stopping drinking, steroids, but also supportive care as well. It's common in patients with obviously a history of chronic alcohol use, and it can be a bit of a giveaway in questions in finals as well, but it also can be a bit of a red herring as well. It often presents with things like jaundice, nausea, vomiting, and like we said, liver enzyme abnormalities, so deranged LFTs and things like that. So, moving on to question 3. A 55-year-old man with a history of gallstones presents to the hospital with jaundice and fever. His liver function tests show an elevated ALP and an elevated GGT. An ultrasound reveals a dilated common bile duct. What's the most likely diagnosis? Fine. So the answer in this case was A. So cholestasis due to some sort of biliary obstruction. So the patient was presenting with jaundice, a fever, and an ultrasound that showed that they had a dilated common bile duct. They're all signs of biliary obstruction, things like gallstones, particularly in his case as well, given that he's got the history of gallstones in the stem. The elevated ALP and the elevated GGT also kind of are supportive of the diagnosis of it being an obstruction somewhere. So things that can cause obstruction include things like gallstones, cholangitis, or a tumour or something like that. So in terms of gallstones, lots of people talk about the 4 Fs as risk factors of kind of developing gallstones. So we think about the 4 Fs of being female, being fat, being over the age of 40, or being fertile. So in terms of clinical features, gallstones can be asymptomatic as well, but they can also present symptomatically. So we call that biliary colic. So it would present in kind of an OSCE or a multiple choice scenario with somebody who's presenting with very acute kind of right upper quadrant pain that can sometimes be epigastric in nature as well. And the kind of classical symptoms would be that it's after eating a fatty meal, it makes them feel nauseous, makes them vomit, but it also resolves within a few hours of eating as well. And it's generally that association with eating fatty meals as well that should ring alarm bells for it as well. In terms of complications of having gallstones, so things like cholecystitis, so that's an inflamed gallbladder where you get right upper quadrant pain that doesn't go away with a fever and Murphy's sign as well on examination. So the stone can get stuck in the common bile duct as well. So that's where you get jaundice, things like dark urine and pale stools as well. So cholangitis as well, which is kind of a biliary infection. So you get Charcot's triad in cholangitis as well, which is quite high yield for final year exams as well. So Charcot's triad is fever, jaundice, and right up quadrant pain as well, and that's quite commonly tested. And ultimately, gallstones can also lead to pancreatitis. So your classic pancreatitis symptoms like epigastric pain radiating to somebody's back with a high amylase or lipase. They often present quite unwell with nausea and vomiting, and that can also be secondary to gallstones as well. So in terms of diagnosing gallstones, the first line treatment or the first line diagnosis would be ultrasound. So that would be the first thing that we'd really do if we suspected it in A&E or kind of GP or anything like that. But also we can use MRCP as well to have a look at bile duct stones and ERCP as well to kind of break up the gallstones, and it's diagnostic and therapeutic as well. In terms of what you'd see on your investigations if somebody has gallstones, if they've got an infection, you'd see that their white cells and also their CRP would be elevated. In terms of their liver function tests, the bilirubin would go up because there's an obstruction, so that causes the bilirubin to rise. And also in just another kind of obstructive picture, so raised ALP and a raised GGT also fits with that. And obviously if they've got pancreatitis as well, like we had a chat about before, it can cause their amylase or their lipase to raise as well. So in terms of treatment, if they're asymptomatic, we don't need to do anything about it. We can keep an eye on it unless they develop any complications like we had a chat with before. If they're symptomatic, the first thing that we do is give them some pain relief. So things like NSAIDs, ibuprofen, but also antispasmodics can also be really, really helpful with kind of the colic symptoms that you get with gallstones. So things like hyoscine, you often see prescribed whilst they're waiting for a definitive treatment. So in terms of a gold standard for symptomatic gallstones, a laparoscopic cholecystectomy would be the gold standard because it removes the gallbladder and also ultimately removes the problem as well. So it means that it won't recur and they're symptom free. Other things include like an ERCP, like we said before, so that's removing the stones from the bile duct, but also in non-surgical patients, so patients that can't have surgery, can't go under a GA, you also see people using ursodeoxycholic acid as well, to try and help with that as well. So, moving on to question 4. A 62-year-old man has known cirrhosis. He presents with confusion and drowsiness. His family reports that he's been sleeping excessively and he's developed some hand flapping movements. What's the most appropriate initial treatment? So the answer in this case is lactulose, so A. So this patient's presented with symptoms of hepatic encephalopathy. So that's a complication of cirrhosis, so scarring of the liver. And it presents when somebody's got elevated ammonia levels. So that crosses the blood-brain barrier and affects somebody's brain function. So it can cause them to become confused, sleepy as well, like we said in the stem. So lactulose is the first line treatment because it promotes kind of ammonia excretion by making the colon more acidic. And then we can also use other things as adjunct therapies for kind of recurrent cases. But most people go on lactulose first of all. So in terms of grading hepatic encephalopathy, it's split into 4 grades, obviously with grade 1 being the least severe and grade 4 being the most severe, with lots of people that are in grade 4 often going straight to ICU, in a coma, unresponsive as well. So I'll give you a moment to read through those. In terms of the person that's been in this stem, we'd probably say that they're in either grade 2 or higher hepatic encephalopathy. So probably more grade 2 because he was sleepy, he was a little bit confused. He also had that flapping tremor that we talked about, which is quite commonly seen in hepatic encephalopathy and could come up in your OSCEs as well. The other thing that is quite commonly tested in finals is that they say they've got kind of a sweet, musty smell to their breath, and that's called feta hepaticus, and we can see that in hepatic encephalopathy as well. So that's just one to kind of keep in the back of your mind. So, question 5. A 50-year-old woman presents with fatigue, itching and jaundice. So her blood tests reveal an elevated ALP and IgM and AMA. What is the most likely diagnosis? So in this case, it was primary biliary cholangitis. So primary biliary cholangitis is a chronic liver disease which mainly affects middle-aged women in your finals. It's characterised by positive AMA antibodies and also an elevated ALP as well. Similarly to non-surgical gallstone patients, ursodeoxycholic acid is the first line treatment. So that's one just to keep in the back of your mind because it sometimes can come up in your finals as well. It's less common than things like gallstones and pancreatitis and hepatitis and ascites like we talked about before, but this is probably one of the more niche things that does come up in finals ever so often. So in terms of what causes PBC, it's an autoimmune process. So the destruction of kind of your intrahepatic bile ducts. When they're destroyed, it causes bile to build up and causes inflammation and fibrosis and cirrhosis of the liver. and that can lead to liver failure if it's untreated as well. In terms of how patients would present necessarily in finals or potentially in quite a mean OSCE, some early symptoms include the ones that we had a chat about in the STEM. So feeling tired, itching due to increased bile salts and bilirubin, but also it can cause a dry eye and dry mouth syndrome called Schrogen's association. So in terms of later symptoms, that buildup of bile salts causes jaundice, pale stools and dark urine. It can also cause some right upper quadrant pain, obviously with the liver cirrhosis, and it can cause the liver and the spleen to become enlarged as well. In terms of blood tests, you'd see that the ALP and the GGT would rise because of that obstructive kind of picture. It would cause some elevation of AST and ALT, so it would derange your liver function tests. The main thing to look out for in kind of finals scenarios is an elevated IgM, but the most specific thing for PBC is positive antimitochondrial antibodies. So that's kind of going to be the dead giveaway in your finals and things like that. In terms of imaging our patients, ultrasound would be kind of the first thing that we do, but also an MRCP can be useful to exclude similar diagnoses like primary sclerosing cholangitis, which we'll discuss further on in the session. In terms of kind of to confirm the diagnosis, the patient sometimes would need a liver biopsy. It's not necessarily always needed, but obviously if there's diagnostic uncertainty, then we can biopsy the cells to test to see if that's what's going on. So I'll hand over to Alex. He's going to do the next 5 questions, and then we can all answer your questions at the end.
Okay, so I'll just start by reading out question 6 then. So a 21-year-old male presents to the GP with yellowing of his skin. On further questioning, it is revealed that he has a tremor and has been experiencing some depression. What is the most likely diagnosis? Okay, so the answer was A, Wilson's disease. And we'll get on to why that was the answer, because we're going to talk a little bit after the next question about causes of jaundice, thinking about pre-hepatic, intrahepatic, and post-hepatic causes. So if we move on to the next question, and then we can speak about the other things in more detail. So I'll read this out. A 34-year-old female presents to the GP with jaundice, a fever, and amenorrhea. She has no history of alcohol use. Blood tests reveal a raised aminotransferase, so ALT and AST, raised immunoglobulin G, smooth muscle antibody, and antinuclear antibody. What's the most likely diagnosis? Okay, so the answer was autoimmune hepatitis. So if we start by thinking about pre-hepatic causes of jaundice, so Gilbert syndrome, which is a raised and unconjugated bilirubin causing the jaundice, usually in response to stress like fasting and illness, and you don't need to treat it. And just as a sort of recap, so red blood cells are mainly broken down in the spleen. So it becomes unconjugated bilirubin before it's conjugated within the liver. And then you have your hemolytic anemias. So this is just premature breakdown of red blood cells, usually due to like a sort of the red blood cells, sort of their sort of protein structure is in such a way that it predisposes them to vulnerability of breakdown. Typically, this would present with anemia and a raised bilirubin when you do the blood tests, and there'll also be jaundice, obviously. So if we go on to the next slide, which is intrahepatic causes of jaundice. So it's important to break these down into different causes of intrahepatic jaundice. So the first ones we think about are the metabolic causes. So hemochromatosis, which is an autosomal recessive mutation of the HFE gene, presenting with mainly sort of the pigmentation and mood disturbances. They have raised transferrin and ferritin with a low total ion binding capacity on blood tests, and you can do an MRI to quantify the amount of iron stores within the liver and sort of cardiac stores as well. And the treatment is venesection. You then have Wilson's disease, which is again autosomal recessive, typically presents with psychiatric and neurological signs. And one of the stems to question 6, the patient presented with jaundice and also a tremor, so that's like the Parkinsonisms. They also get Kaiser-Fleischer rings, which are these copper deposits within the Descemet membrane of the cornea in the eye. On blood tests, they have low serum chalcoplasmin, which is essentially a serum copper transportation protein. They also have reduced total serum copper, and you treat them with copper chelation, so penicillamine. And then, so another metabolic cause is alpha-1 antitrypsin, which is a autosomal recessive metabolic disease. Typically causes emphysema, so the obstructive lung picture, but also causes liver cirrhosis and again the intrahepatic jaundice. So the next slide is a continuation of intrahepatic causes of jaundice. So we've spoken about the metabolic, so if we speak a bit about the autoimmune. So autoimmune hepatitis, which is what the second question on jaundice, so question 7, was about. You typically get a raised immunoglobulin G, smooth muscle antibody, anti-nuclear antibody, along with the jaundice, associated symptoms with that. You treat it with steroids and immunosuppression, such as azathioprine. Primary sclerosing cholangitis, associated with ulcerative colitis. Typically get beads on a string on MRCP, and you treat it with ERCP to stent, and also sort of you can do the bile acid sequestration therapy as well. So then you have primary biliary cholangitis, which is all the M's, so middle-aged women, raised IgM, anti-mitochondrial antibody, and this you treat with, as we've spoken about this condition earlier, so it's the urodeoxycholic acid. Other causes that are important to consider, so hepatocellular carcinoma and cholangiocarcinoma. We've spoken about a few of the other, actually more common causes of intrahepatic jaundice earlier in this lecture, such as viral, alcohol, and NAFLD. So the next slide, so post-hepatic causes of jaundice, so essentially obstructive jaundice. So gallstones are your main one, and obviously important to be aware of Charcot's triad when you have ascending cholangitis. You can also get surgical strictures, such as following a lap chole. You can also get a pancreatic cancer that's sort of pressing on the bile ducts, and that would again cause obstructive jaundice. And this is quite a good summary to think about the sort of the way of sort of systematically thinking about the cause of jaundice. This is from the NICE guidelines, or the NICE clinical summary guidelines. So this is, I've sort of put a slide together just to try and systematically go through liver investigations, try and discern where the pathology is. So just in terms of your bilirubin, if it's prehepatic, you'll get unconjugated bilirubin. Raising unconjugated bilirubin, that typically presents with normal urine, normal stool colour. Intrahepatic, which is going to be mixed, unconjugated, conjugated, both going to be raised though, so you're going to get dark urine and normal colour stool. And then post-hepatic, so raised conjugated bilirubin, so it's going to be dark urine and pale stools. And then thinking about sort of like the blood tests, so for actual hepatic pathology, you have to look at your ALT and AST, see if they're raised. And ALT is more specific. For biliary pathology, GGT and ALP will be raised, but again, GGT will be more specific. And if you're thinking about hepatic disease, such as pancreatic disease, such as pancreatitis, then you look at amylase and lipase, but lipase is more specific. Another important sign of liver disease is albumin. So the liver produces albumin. If your albumin is low, it's either due to an increased loss of the albumin, such as in nephrotic disease, or reduced production, such as in liver disease. And also coagulation screen is really important because the liver produces the clotting factors. So you'll get a raised prothrombin time, or INR APTT. Okay, so we move on to question 8. So a 57-year-old male has been diagnosed with chronic hepatitis C for 5 years. He receives a liver ultrasound annually. His most recent liver ultrasound reports nodularity of the surface of the liver and a corkscrew appearance to the hepatic arteries. Okay, so the answer is alpha fetoprotein. So the STEM was talking about screening for hepatocellular carcinoma. So firstly, it was important to identify that he was at risk of hepatocellular carcinoma because he had liver cirrhosis, which was shown on the ultrasound findings, secondary to the chronic hepatitis C. So the most common causes of hepatocellular carcinoma are the liver cirrhosis, secondary to chronic hepatitis C, or alcohol. So you consider screening in these groups. So it was already mentioned that the patient was having liver ultrasound, and the other important test to do is AFP, because that's a marker for potential marker for hepatocellular carcinoma. If the findings were suspicious of carcinoma, then you do a more in-depth investigation, such as biopsy, CT staging, to actually diagnose the cancer. Typically, there's a poor prognosis. However, in early disease, you can consider resection or transplant if amenable. Other than that, you can consider radiotherapy and a few other more specialist treatments as well, such as kinase inhibitors. So question 9. So a 24-year-old female with a history of bipolar disorder and self-harm takes an intentional overdose of 160 500 milligram paracetamol tablets at 6 p.m. yesterday. She was admitted to a medical ward and treated with IV NAC. You assessed the patient at 7 p.m. today. She is still very drowsy and confused with slurred speech. She is tender in the right upper quadrant. You decide to take some further blood tests to assess her, and I can let you read them yourselves. And then the question is, what aspect of her investigation meets the King's criteria for urgent liver transplantation? Okay, so the answer was a blood pH of less than 7.3 24 hours after the paracetamol dose, or intentional overdose. So we'll speak about sort of the actual question, which was why was she eligible for liver transplant, but we'll speak about liver transplantation more generally here. So indications. So the priority is if you have acute liver failure, such as paracetamol overdose or acute viral hepatitis. You can consider it in chronic liver failure. However, there are some quite strong contraindications, such as significant comorbidities. If they have to abstain from alcohol for 6 months, are the main ones. And there's also previous cancer, except for the liver cancer, which may be an indication. Typically, the surgeries, this Mercedes-Benz incision, which is the logo of the Mercedes-Benz, or they do a rooftop incision. Post-operatively, immunosuppression is really important. The regime they give is steroids, azathioprine, and tacrolimus. And you'd also want to monitor for signs of rejection, so both clinically, so like essentially liver failure signs, also monitor the LFTs as well. So speaking a bit about why this patient was eligible for acute liver transplant. So King's College criteria says that if the arterial pH is less than 7.3 24 hours after ingestion, which it was in our case, or if all of the following are present, and you can see them there. And we have spoken a bit about this hepatic encephalopathy before, but the sort of grade 0 to 4 is up there again. I don't think I need to go through it for a second time, but it shows that it is important and used in lots of different clinical situations. So the final question is: a 53-year-old man presents to the GP with yellowing of his skin for the past 2 months. On further questioning, he admits to pale stools. Examination reveals a non-tender palpable gallbladder and excoriation marks over his arms and abdomen. The patient has a background of ulcerative colitis and primary sclerosing cholangitis. What is the most likely diagnosis? Okay, so the answer is cholangiocarcinoma. So this slide just goes through briefly sort of what cholangiocarcinoma is. So adenocarcinoma of the biliary ducts, heavy associations of primary sclerosing cholangitis, which is also associated with UC, which the stem of the question had. We spoke about earlier the fact that the patient would present with an obstructive jaundice, Corsiver's sign, which is this palpable gallbladder, and jaundice is unlikely to be a gall. It is unlikely to be a gallstone, more likely to be a cancer such as cholangiocarcinoma or pancreatic cancer. Typically, it would be more likely to be a pancreatic cancer. However, given the patient's background of the UC and PSC, it would lean more towards the cholangiocarcinoma. Diagnosis, so you can do it CA19-9, but it's non-specific. Typically, you're going to do a CT or an MRI, and you're going to have to biopsy it. Treatment, so usually it's more like symptomatic relief, such as stenting and ERCP. However, you can consider radiotherapy, chemotherapy. It's important to note that curative surgery is rare. So that brings us to the end of our session today. If anyone would like to ask any questions, we can stay on the call. I think so. If you scan this, this takes you to our sort of link tree. So you'll be able to sign up for the next sessions. There's some feedback that we'd really appreciate, and I'll pop that in the chat now. So yeah, we'll stay on the call for a bit longer just to answer any questions. And yes, these slides will be going up on Medal within the next few days. But we appreciate the feedback.
Yeah, the feedback's really useful. And if you guys have got any questions, then just let us know. Like Alex said, we'll stay on the call for a little bit afterwards as well.
I can see one question is this corkscrew appearances of the hepatic arteries, and then just asking what the cause is. So this was from a ultrasound of a patient who the most likely cause was this the hepatocellular carcinoma, I think. So maybe
Yeah.
question.
Yes.
Was it this one? Okay. So essentially, my understanding of the corkscrew appearances of the hepatic arteries is when you get quite end stage liver cirrhosis, that causes the congestion and therefore the increased pressure within the arteries that would cause them to sort of kink in such a way that they'd appear to be corkscrews. So it's more a sign of quite advanced liver cirrhosis.